Yes, unseen and oral surgery. So basically, I'm just going to give a couple tips. What you can do now, what you can do during the course of the exam, and basically to take away message. So tips for now. Obviously, you have exams coming up. Some of you tomorrow, some of you in a month, and they kind of different scale. Some of you graduate, some of you year 3, year 4, etc. I actually stuck in the same boat. I have my exam coming up in November, and it's sort of similar with unseen cases and stuff. So it's kind of good to develop that skill. Exam is a skill, and it's always best once you have an exam date, use it as your deadline, and then you can stuck in early with your revision, and basically probably best to work out what you've missed, to revise all the gray areas by reviewing all the previous lectures and all your materials. And just make a schedule. So schedule is important, but also don't forget about breaks. Have good sleep. Don't forget about breaks, and you know where to revise. Some people prefer revise in the library. Some people prefer do it outside or at home in silence or with TV on. So just know what your sort of comfortable area to revise in, and talk to others. So don't forget peers, talk to others, and maybe create a little group, WhatsApp group. Maybe you've done it already. And talking to other, you can practice exams with each other. Questions are going to be standard, especially unseen case. You all have seen cases as well. You're going to be presented. You can answer questions on those to your peers, etc. And they cover similar topics you're going to have in the actual exam. And we are talking about basically a skill of sitting an exam, but it's useful for your future practice as well. The more cases you actually see, the more clinical sort of clinical thinking, shall we say it, and critical clinical thinking you develop. And practicing speech is important, I feel, not only for public speech, but also because you're going to be performing in front of the exam or in front of the exam and an actor. And that's performance. Obviously, sometimes you can get carried away with being just nervous of how you look or how you come across to examiner, etc. So once you practice that with your family, with your friends, with your peers in front of the mirror, basically talking to yourself, listening to your internal voices, you kind of know already and cover certain grounds, so you don't need to worry about that. So you can purely focus on actual scenario and what comes out of your mouth as well, because otherwise you just get a bit stuck with things. And when you revise, it's important to reward yourself, and by rewarding yourself, I mean a bar, chocolate bar included. So just treat yourself, and it's sort of good motivational point that I don't know, you don't have a dessert until you learn radiolucencies in oral surgery or white lesions, etc. That's important. Although once sort of time comes in, and then you obviously feel always that you're not entirely prepared, but that's normal. So don't worry about that. It's normal to be nervous. Does it go away? I must say that it does, but not entirely. So it just you kind of react to that differently. So I still get nervous all the time, and I'm sure senior lecturers, professors, they also get nervous if something goes on. But it kind of sort of at lesser extent, because as you experience more things like that, and in such profession like dentistry, if you go on and on, you can sit exams after exams after exams, and it's almost never, and it's not going to be it's not even called exam anymore. It's more of like an appraisal, because then you kind of get so comfortable with exams that you just it's just a conversation between two clinicians, shall we say. So the sooner you treat that as a conversation about the patient is paramount importance, and it's two clinicians, you behave like you qualified colleague, that it's going to put your mind at rest a little bit, so you don't feel like you actually been examined. But it is intimidating sometimes. So when you have the preparation time, make sure you utilize that really well. Take notes, and by taking notes, you're already creating a structure to your answer. We're going to be going through the unseen case that you've probably seen now. And although I must say this unseen case that I've sent is a bit of a monstrosity, it's highly unlikely you're going to have anything near like that. But the more sort of things we cover today, I thought the better. So I put like quite difficult case. But be structured about your answer, and this structure doesn't come from the knowledge that you think station is about. The structure comes from the question. It's not about what you think the theme is. So don't base the structure of your answer on a theme, because then you can get easily carried away, and then the examiner will be forced either to ask you leading questions and spend time on that. So just base your structure on actual question that is in front of you, and highlight key points. Think before you speak. So once you start exam, take a moment. It's always fine. I never forget. I think it was what his name, Tesla guy. Oh, Elon Musk. I think he was asked a question, and then he asked for a pause, and then he took about 10 or 15 seconds pause. And obviously, when there is a discussion, it's noticeable 15 seconds. But then he came up with a brilliant answer to that. So no matter how think your brain fast, very fast, but the more sort of filter you put it through before you speak, the better quality speech you have. So just bear in mind that, and don't get caught up. So you can get caught up going on and on of some sort of things. Obviously, the structure of your answer, that you cover your basics first, and then from basics you can go into advanced stuff if you have time. And by advanced stuff, I mean you can cover some extra grounds, or you can go into evidence. You can even maybe cite a couple of papers and give percentages, etc. But don't get carried away. Examiner will more likely to lead you, because examiners would be normally feeling that they need to steer you back if you get carried away. But less you get sort of caught up with your own thoughts about certain topic, they sort of stay in tune, stay in line with the answer that you give, and then give with your speech and with pause, you give examiner an opportunity to interrupt you. Because personally, myself as an examiner, if somebody talks at me, what can I do? I mean, I try my best, but if they talk at me, I let them talk at me, but then they wouldn't cover something that I really wanted to hear from them. So just bear in mind that, and lead the presentation. I mean, to be honest, unseen cases and OSCEs, it could be an interviewer led or interviewee led. Both of them are possible. So you need to really tune into examiner's body language. So you need to read examiner almost. You need to be led by them, but then again, they will give you an opportunity if you need to lead now. So if it's an OSCE station with an actor, you take the lead, and really examiner is there to steer you if necessary. And only actor can then take a lead back and start asking you, I don't know, some communication related questions. If it's an unseen case and you examiner having a discussion, then it's a bit about both of you. An examiner can actually take lead and bombard you with questions. And by saying bombard with questions, examiner might come across a little bit mean with that, but actually what they like to do is have a good quality discussion. So if they actually bombard you with questions, it's probably that they're quite enjoying what's going on at the moment. So just keep it up, and don't think about sort of, are you doing the right thing or not? Because then you just consume your thought with this unnecessary sort of just time consumer, basically. And again, as I said before, once you know your scenario, you made a structure to your scenario, then on that skeleton, you will slide the answer for that particular unseen case or particular OSCE station or a medical emergency, etc. And cover basic points. I mean, with medical emergency, I must say that everything you need to cover is basic. And there is basically things you just need to say, and this is it. They're quite straightforward medical emergencies, and I would say they are those that normally give you points, just so you can, on another station, if it's a bit too difficult, you can be let down a little bit, okay? So take medical emergency stations as your star key points that you can actually get some extra points, so you perform well overall. But then in more advanced orchestration with actors, with consents, with discussing risks, discussing post-operative instructions, etc. Then you need to cover basics, and then once you cover basics, you can go into advanced. So with the patient, you can go into percentages, what do's and don'ts, pros and cons, etc. And then maybe even citing some evidence. Not necessarily with actors, you probably would need to give an first author name or where it comes from. You can just say National Institute for Clinical Excellence or something like that would be enough. But with examiner, you may as well just say exactly what it says and exactly who wrote that, and maybe year it's been done, like for endocarditis prophylaxis and stuff was quite recent update. So if you have something related to endocarditis, and then you say there is nice guideline, blah blah blah. They recently had an update. You say the year, and that's what it said. Then it will be great. And looking into guidelines, by the way, check the whole thing. Don't just look into bullet points, because if I don't know if you're aware or not, but for infective endocarditis, it's actually they actually describe how would you tell the patient what infective endocarditis is. You know, because sometimes we overcomplicate things, but NICE actually done it for you already. So all you need to do is just read it up. And with these things as well, just go into associated department. If you want to know what's the wisdom tooth extraction is in lay language, just go to oral surgery department and ask them for patient leaflet and read the patient leaflet. Collect them. I don't know. It's probably will. It's recorded now. So if all of a sudden 100 of patient leaflets missing, that's on me. But just have a look, and maybe you don't have to you can take a picture of them, so don't basically destroy their resources. But have a look what it says there, because that's exactly what you would explain to patient. So you don't need to go into more advanced detail for that. And this is just typical unseen cases for oral surgery, really. I mean, OSCEs will be a little bit different. OSCEs might be about instruments, about taking tooth out, about certain different things. But for oral surgery, typical unseen cases, it's a white lesion. So it's a bit of a mix with oral medicine sometimes. Radiolucencies, team JD, I doubt there will be a lot of pain or neuralgia, but you may as well have, depends on where you are. Complications of extractions, I guess this is one of the most common things, like oral antrum communication or nerve paresthesia. How do you explain that? Maybe there will be a patient, or maybe you just need to describe the standards regarding this, or explain the wisdom tooth surgery with a high risk of nerve. Trauma, I mean, to be honest, for oral surgery, it's unlikely you'll have dental alveolar trauma. I think it's mostly related to pediatric dentistry, I feel. But it might be jaw fracture, and those will be basic questions, so you don't need to expect something particularly. But those are the main themes basically you can expect. And covering basics, I mean, you can freely start with extractions and all associated complications. You already have plenty to talk about, and then you can slowly cover the rest with associated evidence that you have. And basically to take don't fear the unseen, and listen to a tutor. If you still have time to exam, just go to your clinic, see if tutors are up and about, and start a conversation with them. It's not necessarily that you need to squeeze out of them what exactly questions are like, because first of all, they probably don't know. Secondly, it's intimidating for them. But if you have a colleague to colleague discussion in terms of different topics and maybe past year papers, etc., that can be useful. And I just put logos of your best friends for that period. It's not actually an exhaustive list, but one of those frontiers that you can go for: NICE, SDCEP, Reader's Guideline, Cochrane, obviously PubMed is a database, and Dental Update potentially. I mean, but there are plenty more. And some things like, for example, MRONJ, osteoradionecrosis, phosphonates and stuff, they're actually covered by different international literature as well. So Just don't sort of go and stop on a certain particular aspect. But again, as I said, cover basics, and once basics are covered, then you can go into advanced stuff. And I think now we could potentially just go ahead with the case. Would you like to share it, Sam or Owen or Niji? Do you happy to share the case? Do you have it handy? I don't think so. I have it on this computer.
Yep, I've got it.
I can get it up as well.
Anyone have any questions?
Have you got it
so
up, Niji? Have you got it up, Niji? Or do you want me to do it?
Actually, yeah, you go ahead.
Yeah, so I mean, unseen case would be sort of similar to.
Is that okay?
Yeah, that's perfect. Actually, I like your editing. Wonderful.
Thank you. All Niji. I won't take any credit.
Thank you.
Wonderful. Right. So so let's have a look. So, I mean, it's quite common to have a scenario that explains who you are. So we're just going to be covering more than actually case asks you to cover. So that's sort of, although it's quite significant case, but as I say, it's a bit of a monstrosity case. So it will be way less than that. But if you just start reading that, you probably will have about 10 to 15 minutes to go through the case. And to be honest, that's plenty. So you can spend good 5 minutes actually going through the scenario again, and then highlight extra bits, and then spend the last 5 minutes on sort of making then a structure. So I personally, how I would approach that, I would just be highlighting key points. Now, in this scenario, key points asking you straight away, you are VT here, okay? And then you have a patient, you know they age already, so that's fine. That's another thing you can highlight. And then requested urgent appointment. Now, if urgent appointment is requested, you can also think that there's not sort of, it's bothersome to a patient, okay? Appointment is given, it's end of your clinic, and then patient concerned about discomfort and soreness in her jaw. So that's quite common. Along that, patient complains of the numbness. Now that's worrisome. So that's complaint number 2. Okay, numbness around the lower lip, chin, right hand side. So you now straight away turn into your anatomy knowledge, and you already hear what it could sound like potentially. Patient then had a course of antibiotics for previous infection and swelling associated with that region. So now this case steers you into that they had previously experienced infection, they had antibiotics, so you can assume that if that's in the case, then it's more likely has something to do with that. So it's part of the same problem. You perform an examination, notice no extraoral abnormalities, so that's good. But the only thing you notice is bluish discoloration along the buccal sulcus, and you can hear an eggshell. I mean, eggshell, just a classic sign, but this is not to steer you well. It's actually to rock your boat a little bit instead. So cracking noises when patient opens her mouth. Buccal sulcus and associated bone expansion are painful to touch, and they occupy quite a significant area. So you already know so the way you structure it is exactly like you fill in when you see patient in the clinic. You have patients' demographics, they're minimal. If they've not been given, means that's all you need to know. Then you put the complaint number 1, complaint number 2. For restorative, it's important. For oral surgery, you will probably have one problem, so you need to combine them probably as the same thing. So I would just combine them all together. But it's important that the soreness and the numbness is specifically divided into 2. So then you go with history of the complaint. They had previously antibiotics for infection associated with that region and the swelling. So that's a bit of history given to you. Now you perform extraorally, it's all clear. So examination, intraorally, you have your findings. and then they give you medical history, and then medical history is already filled with stuff. Medically, patient is asthmatic, okay, and they take blue and brown inhaler, and they also have bleeding disorder for which they had desmopressin injection in the past. Patient is allergic to lemons and latex. Medical history given to you. They do have allergy, so you might have questions about that. And if it's an oral surgery unseen case, then definitely you will have a question or two about that. So everything that mentioned in medical history is of importance, and nothing that would be mentioned there has nothing in relation to discussion that you will be having. But again, we now finished reading the case, and you highlighted a lot of things. You might end up crossing the whole thing, but obviously the last 5 minutes you will spend to actually clearing it up and creating a skeleton, proper skeleton of what you have. So it's just in front of you, and you can take notes, and you should be able to sort of bring them with you, etc. And that should really help you with the process. So make sure you utilize the time and just be tidy about that. So practice with your colleagues if they have seen cases they're going to be presenting. Maybe practice with each other to get the key points. But then again, as I said before, any clinical presentation has the same structure, and is exactly the same structure as you have when you fill in clinical notes. You have what patient's here for. Now you have patients here as a VT, as an urgent appointment, and then you go, your complaint, history of complaint. You can have medical history after that, or social or dental history, but you can also have medical history instead. They can be swapped sometimes. And then you have your examination, investigation. So we had an X-ray. Shall we have a look at the X-ray? All right, so have a look at the X-ray, and obviously this is a killer X-ray. So I doubt you can have anything sort of close to that. But there's several problems with this X-ray, of course, and this X-ray straight away shakes your boat to the point that eventually you don't know where you start. But simply enough, any X-ray have same structure of how you describe that. So first of all, you start with X-ray that is. Once you sort of have a clear idea what X-ray that is, you can notice that they're quite high up. You can see floor of the nose, sinuses, etc. You then go with examining general things. You would say, I guess, for the purpose of this case, bone level and things like that is not significant importance. And I guess for oral surgery, personally, as an examiner, I'm more of a problem focused once we have complex patient like that. However, you can and you probably should describe X-ray as you would normally, starting with what patient had, and probably finishing up with the most pungent thing. And the most pungent thing about this X-ray, obviously, is the large cyst in lower right quadrant, and that's what's symptomatic. That's what about the case. Okay, again, so you'll have limited time to discuss your case, so you want to steer quickly into what you have. So again, it's important if you have big X-ray that you already make a skeleton of what you need to say about it. And finishing off that, there is also a mini plate with screws. Case doesn't tell you anything about that, so it could be anything in this particular case. So and then you will be just basically shaking with the first question, which is the vague question like you can ever get in the world. Describe what you see. We're going to discuss every single point, but again, an examiner can ask you, so tell me what you see. I would normally expect that examiner probably will shift X-ray closer to you, and then you describe, that's an orthopantomogram, OPT, OPG, however you like to call it, full OPG, because some departments do like sectional. And then you discuss of an adult dentition, bone levels, fillings, sort of you can discuss absent teeth, missing teeth, impacted wisdom teeth, and then you go into a juicy part of that X-ray, which is basically a large radiolucency that spins across coronoid process, angle of the mandible, symphysis, parasymphysis, so basically body of the mandible, and then basically, sorry, body of the mandible associated with this, and this teeth, which basically gives you a scenario already, and also associated with the previously placed mini plate with screws. For which then now I have so many questions I can ask you. So examiner at any time can start asking you questions. And to be honest, I do like to have a good, nice discussion and just basically be carried away with the student of basically where we end up, nobody knows. But generally, those questions that I listed are questions that you should envisage. And just for the purpose of now, we're going to go through a lot of questions, but it's not like you're going to have loads of questions. You're just not going to have time. And before, I got a question actually of what if you don't cover everything and you run out of time? For unseen cases, that's absolutely fine. It's not the quantity, it's the quality. You just need to say right things, and also not necessarily only one thing is correct about this case, okay? All surgical cases would have several options for treatment, and the best way you structure your question, your answer, sorry, is basically you think ahead. You know what this patient is about. You know what they're here for. You can then now come up with a differential diagnosis. Okay, so we're not going to be skipping all the questions, but basically, if you go with a patient main complaint, you would say that this is the radiolucency, well-defined. So again, when you describe it, a well-defined radiolucency spans across blah, blah, blah. I mean, from this X-ray, I can potentially suspect it's a unilocular. So it has only one area. It doesn't have any sort of separating septums. The border of the mandible is thinned out, etc., etc. So, and then obviously, the full OPG is given so you can compare it to the other side, and you can see where the link, where the ID canal goes through, so you can suspect on the other side has pretty much similar direction. So you can say what it involves. It definitely would involve ID canal, involve second and first molar teeth on the lower right quadrant. Well, actually, the second premolar as well involves as well. So that's what makes chief complaint, and it's probably get infected. So that would, you could describe what you see on an X-ray. Talking of patient complaints, and their main complaint is soreness, and the fact that it's been sore for quite some time now. But again, I can ask you a question then. So how do you proceed? And again, the very first thing that you highlighted, that you are a VT. So ideally, you should be placing you in position of where you are. Now, in different scenarios, you can be said that you are a hospital dentist. So then you will be probably a little bit different. In place of a VT, with this complex case, you can run a couple of special investigations. Again, you can test vitalities, you can test pocketing, you can give a good sort of palpation of the eggshell-like swelling of the alveolus. And when the examiner going to be potentially asking you questions after that, you always can pause and ask, can you repeat the question, please? Okay, so at any time you can do that if you didn't get something, or if you need to, you can ask even, do you mean that or that? So if they ask you something you're not entirely sure of. And with this, how you proceed, this can actually touch up on how would you refer patient. Would you refer, what do you think is going to happen to patient? But again, even though you can come up with differential diagnosis, your treatment plan will start with immediate management of how you're going to provide patient with pain relief. So this patient is in pain and they come to see you because they have discomfort. They didn't come to see you because they know they have radiolucency, which might be cyst, or might be a malignant lesion, but they came because they in discomfort. They also have numbness in the lip, in the lip and the chin. So you're gonna provide them with some management for that, and what you can do is pain management. And then for this, you can also say, what's your backup evidence? Why would you do that, and how, why it works well? And you can provide. I would treat it probably mild to moderate, as they say, discomfort or soreness. They didn't present with extreme pain, I think. So you can prescribe them something mildly, but again, once you're prescribing, you need to be careful of what you're prescribing. Now, paracetamol is pretty much safe for everybody, but ibuprofen, especially on a patient with asthma, you can say that the evidence-based pain management protocol for mild to moderate pain is paracetamol and ibuprofen. However, from medical history, I'm aware that patient has asthma and they might be allergic. So now you can go into evidence of why we actually think they might be allergic. What's the mechanism, and that's a little bit advanced. So I wouldn't go there unless you asked. You can only say, I would ask patient if they normally take ibuprofen, if they can take it, and if they can take it, I would advise them to take that. So with the differential diagnosis, then obviously this is a sort of, for oral surgery point of view, it's a clear-cut scenario. It's not to confuse you. You would basically focus on that lesion in the right hand side quadrant, because that's the main and probably only chief complaint of the patient, and that's what you can see on an x-ray. And your differential diagnosis could be anything. So you need to know your radiolucencies. Those include cysts, tumors, and malignancies. And it could be anything. It could be radiculous cyst, it could be dentigerous cyst, it could be keratocyst, it could be a ameloblastoma. There are few sort of potential. So it's and you need to know evidence. So why do you think so? And then you can come up with evidence that you read about radiolucencies. It's a location, it's clinical presentation. So you can see eggshell cracking noise. Now that's worrying. To me, it might be an ameloblastoma, because it does thins out the cortical bone of the jaw to the point that when you press on it, or when sometimes patients even open their mouth, it has like a eggshell cracking noise to it. To be honest, I only seen it in my life like three, 4 times, but it's one of textbook signposts. But it could be dentigerous cyst, or it could be a keratocyst, and you need to know classification, that keratocyst is a tumor, etc. And you also see associated plates. So I mean, if I was there examining you, I would ask, do you know what this plate might have been placed for? And then you can say probably jaw fracture. So that covers a couple of things. And is it relevant for case? Not really. I mean, to be honest, I tried to find something without this, and I just thought I would just include that. So to be honest, we can ignore, I guess you can be asked about, tell me about the upper right wisdom tooth as well. So some secondary things, they can have a discussion, and then you can just basically describe what you see on an x-ray. But basically differential diagnosis, as we mentioned before, those radiolucencies, you would benefit from knowing histology, because the then tutor, once you reach that point, can say, so this is histology report. Can you read that for me? So you read histology report, and normally it would say what the diagnosis is, but you do benefit from knowing some sort of highlights of different lesions. I mean, keratocyst would be presented slightly different on a histology report compared to radiculous cyst. And again, could it be radiculous cyst? Could be, but highly unlikely, because it's quite large. But again, it could be because it didn't significantly displace teeth. Although some can do. So there's lots of points of discussion. So once you know those lesions well, once you read about them, all the radiolucencies in the jaw, then you should be quite sound about that. And for example, then tutor can say, so it's been so you performed the biopsy and it came up as a keratocyst. What's your treatment plan? So obviously by that point, patients in the hospital, they had biopsy in the hospital, and then they came up with a keratocyst, and now you have treatment plan for keratocyst. So then you go basically into assumption that biopsy been performed. Biopsy for this would be also called marsupialization. So you would hope since then maybe lesion decreased in size, but obviously it's quite difficult. So you can then consider two treatment options here. Although biopsy been performed, but you can have marsupialization as an option. Marsupialization is basically creating a window, making sure that it doesn't heal. So you basically will pack it with a gauze that's radio opaque, and then also take as much cyst as possible. You can take aspirate as well, but you can do enucleation. So I think in this case we actually went ahead with enucleation, with complete enucleation. And we had to sacrifice the second molar. So you might be asked the question, would you take out teeth? And the ideal answer to me in oral surgery would be that you say it's a poor prognosis for both molar teeth, but although you would probably include it in constant form, you would explain to the patient that especially if the patient is keen to keep those teeth, they'll try their best, but those teeth might be sacrificed just to have success of the overall procedure. Obviously, with marsupialization, there are more chances to keeping those teeth, but enucleation is an option. And I think in this case, enucleation went ahead because obviously you might ask, so pros and cons of marsupialization and pros and cons of enucleation. So again, marsupialization is a less dramatic procedure. There's a low risk of sacrificing structures, particularly we worried about nerve. And we do know that the nerve is involved because patient has numbness, which is another actually red flags why this lesion in your differential diagnosis could be malignant. So because the nerve usually get pushed away, but in this case, I think it just got pushed away to the fact that it just got slightly numb. So it wasn't invaded or anything like that by the tissue. In case of ameloblastoma, it could be invaded and could be quite aggressive. So with marsupialization, there are also negatives. For example, they will have to be with a gauze for quite a long time. It could be 6, could be 8 months until the lesion shrinks down. They need to come for follow-up appointments to change the gauze. It smells. It can irritate gum, so it is uncomfortable, etc. It can get infected, etc. So all sorts of things. Whilst enucleation, although has probably more risks for ID canal and associated nerve, more risk for the teeth associated with this lesion, it does have a benefit of basically getting rid of it in one go. But you're risking, because it's a large lesion, and you're risking that something might stay and might sort of create daughter cysts, especially with keratocyst. Okay, so but again, as I said, I personally prefer marsupialization, but it's guided by patients, so you can mention that you would discuss all the advantages, disadvantages with patient, and you would then tailor treatment plan individually for patient after patient heard all the options and all the sort of sequelae they would experience with a certain treatment plan. And now treatment is completed. Would you have any concerns? So once the treatment is completed, let's say we've done everything, we enucleate the cyst, everything's sutured. In this particular case, we have removed a mini plate and we removed a second molar because it was very loose and you can't leave it. We basically were envisaging that, first of all, the numbness might not get back. So we were hoping it will get better. I think in this case, it's fine now, the numbness. But you do need to envisage also things like pathological fracture, because now you enucleated the cyst and you left a very thin border of the mandible. So enucleation is risky in this case. So again, this is another sort of disadvantage and risk of enucleation that some patients might be willing to take. Then yeah, what's next could be asked. So how long would you follow up this patient? I mean, again, it's going into sort of advanced, but managing cysts, you would normally follow up a patient with keratocyst for at least 5 years. So that's sort of an important point, I guess. That's good to know if you know that. And again, whilst we talk about that, you don't have to answer all the questions. You can sincerely say, I actually don't know that question. I would consult my colleague or my senior colleague regarding that, just to make sure we'll make the right decision of how long we follow up that patient. But again, if that's the question, then you can probably envisage that you're not going to really discharge that patient too soon. Okay, so I wouldn't take numbers out of the air, but you can show examiner your critical clinical thinking. You're saying with this particular, I don't know exact answer to that question, but I do suspect with this particular lesion, there will be a period of some follow-up, especially the question actually tells you long term. So you can say that, you know, so even questions that that they ask can lead you and steer you into the right direction. But if we just go back to the medical history, so now sort of if we're finished with the main problem, but you actually might be asked questions on medical history, and to be honest, I think you will. So if we just go back to the, yeah, wonderful. Right, so what's important? So first of all, medically, patient is asthmatic. They take blue and brown inhaler, and again, blue and brown is great. But you might be asked, what's blue and brown inhaler? So then you might ask, okay, so blue salbutamol. So what's salbutamol? What medication that is? How it acts? What it does? How do you take it? Okay. And then what would you advise patient to do? And then you would normally advise them to bring their inhalers on every single appointment. So that can be potential question. And again, patient with asthma and with pain, so there will be some pain management. So you need to sort of be wary of ibuprofen, well, no, all non-steroids and stuff. But then again, it's getting even more interesting. So a patient has bleeding disorder and they had desmopressin injections in the past. So I tried to find something that even if you Google it, you would struggle to find a clear-cut answer unless you know. So people can have desmopressin injections if they have bleeding disorder for 2 bleeding disorders. It's either von Willebrand disease or hemophilia A. They're quite interlinked, those two, but you would benefit from knowing the difference and knowing similarities as well. Actually, you would benefit from knowing sort of genetic aspect of that, and actually what those conditions are and where do they affect the coagulation of the patient, and basically why is that corrected with desmopressin. So obviously patients with von Willebrand and hemophilia A can have a significant bleed with major surgery, and this does look like a major surgery to me for sure. So it will be interesting to ask a couple of questions about that. So basically in that respect, patient will be managed obviously in secondary care in close cooperation and communication with hematology department. This patient is more likely to be known hematology patient because patient just told you that they had bleeding disorder and they normally, for which they had desmopressin injection in the past. So, but patient might not even know, like, is it hemophilia A or von Willebrand disease? They don't have to. I mean, you can then look through the communication, what you had, and then obviously contact your local hematology team. And then they will help you with management. So you will have a hematology plan for that patient before you go ahead for a regular plan. And desmopressin, again, used for other conditions as well, actually. So I don't think so for desmopressin, you need to know a lot of things in detail because it's quite specialized medication. but you would benefit from knowing obviously hematology related conditions and how they treat it, or what can be done to control the bleeding. And desmopressin is one of those helpers that can help with von Willebrand factor in particular and allow release of that factor from the platelets. So you would benefit from knowing some, again, cover your basics, because to be honest, if you cover your basics in a lot of sort of advanced things like hematology, for example, and I must say, although you need to know hematology, it is an advanced topic, you would benefit. I mean, nobody will ask you how long desmopressin works for, how long it takes to kick in, where it's secreted from, etc., how it's broken down. So those are questions that not up the dentistry street, but you will need to know just basic management of hematology patients. Patient with allergies is very important, and I mean, again, I just put something here just so we have a discussion. I said it's a monstrosity case, and it's highly unlikely. It's more likely you're going to have patients allergic to penicillin, and then you might be asked a question: what antibiotic you would prescribe for this patient? In our case, it's a little bit more difficult. Patients allergic to lemons and latex. Again, latex is easy because you probably had that already, and with latex, you schedule them first in the morning for the procedure, or for your appointment. You would ask a patient what reaction do they have, and some patients have anaphylactic shock to latex. So be wary about that. So if it is an OSCE station with allergy and you have a patient, it might be a medical emergency station with anaphylactic shock. You just explore that a little bit with patient and just ask a couple of questions. But again, you don't necessarily have to waste your time as well if you don't get asked about that. The importance of being allergic to lemon, actually, all citrusy, including kiwi and stuff. If patients are allergic, they might be allergic to local anesthetic as well. So, and well, not even so local anesthetic maybe, but a general anesthetic is of concern. So this can be a point. Again, it's a little bit, I wouldn't say it's basic knowledge, but if you're striving for a distinction, in this particular unseen case, that it's there for a reason. And this patient is probably, you might be asked the question, what modality do you think this patient will be treated with, local anesthetic, sedation, or general anesthetic? And then you can say, sort of weighting all the considerations, knowing the extent of the procedure, that it depends on obviously patient's wishes, etc. But the complexity of the procedure can warrant you an extra help. Now, I've seen this similar things being done under local anesthetic only, but mostly it's when the patient, after listening to all the options from me, they said, I'm really cautious of sedation and general anesthetic. I really want this done under local anesthetic only. But you can't talk to the patient in an unseen case, and you can say, based on the complexity of the procedure, I would suspect that sedation or general anesthetic might be warranted for this case. So then, in pre-assessment, a part of checking all the asthma and bleeding disorders, they would check allergy and have importance out of that as well. Fine. Do you have any questions so far? Any burning questions or related to this?
Yes, I've got a question in regards to the case. Sam, would you scroll down to the X-ray, please?
Oopsie daisy.
There we go.
Now.
First one we got is, would you not marsupialize first and then enucleate later, considering the size of the cyst?
Yes, that's what I would do.
Happy days. And then the next one we got leading on from that was, could this not be a radicular cyst associated with the lower right 5? Are keratosis cysts not more common in younger people going through puberty, etc.?
Beautiful question. Whoever asked that question, really well done. Yeah, that's what I think it is. But again, it came up as a keratocyst. So so I'm telling you the truth. But I was hoping that somebody would notice that the second premolar has something to do with root canal treated tooth. So potentially. But then again, this is sort of like, once you had sort of advanced questions, then that would be interesting point to discuss. It could be, it's unlikely to be a dentigerous cyst. It's unlikely. I mean, I must say as well that this patient did had a wisdom tooth before, which was removed, and we knew about that. So by removing a wisdom tooth, something might have been left over to make it a dentigerous cyst. But this is more of an academic discussion, really. So in this particular case, if you've not been given that the wisdom tooth has been previously removed, blah, 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 then you can just basically, probably your differential would be radicular keratocyst, might be a melablastoma, sort of things.
Okay. A lot of cysts to remember. Well, Dan's very, very happy himself. He's got that. But then we've got another one that is a little bit off topic. It's in relation to oral antrum communications. So they've doing their reading, and what would you do with an OAC less than 2 millimeters? Would you leave it, or how would you treat it?
Okay, so if you're asking me because you're interested from oral surgery point of view, what I do on my daily basis, that's different to what you would probably be answering in your exam. Now, if you want to answer for the purpose of your exam, you need to be really gentle. You just probably, if you ensure that this is oral antrum communication that you have, the best thing would be to say that you would definitely inform the patient of that. You would schedule a follow-up appointment with them as well, just to check how the healing goes in the next week or two. You give them specific tailored postoperative instructions about oral antrum communication in particularly. And if it's less than 2 millimeter, I would strongly advise to leave it as it is. You can they say that you can put loosely Surgicel dressing. You can put a suture, cross mattress suture. You can even say what exactly you would do. But if you created a oral antrum communication that less than 2 millimeters, it does not require surgical repair.
Okay, so in your day-to-day, you put a bit of Surgicel in, but
on my day-to-day, I might consider repair it. It depends how I feel. But again, 2 millimeter, there is nothing to repair. I mean, this is it should heal spontaneously. You just really need to put a lot of effort into explaining patients what to do and what not to do.
Okay.
And if you look into ASDCEP guideline, it will tell you if you prescribe something or not, and when would you prescribe something. And for oral antrum communication, there's something specific that you would prescribe normally. But again, if you have oral antrum communication scenario, you might have a patient with allergy to penicillin. So then here you go. So you'll be a little bit, your boat will be shaken.
A lot to remember. A lot of cysts. Very, very confused when it comes to cysts. So yeah.
I know, I'm confused as well, really. But again, I picked this case. There's a monstrosity case, really. It's monstrosity case for specialist management as well. Just to give you an idea that in your exam, no matter, I mean, it's best if you behave not cocky as a colleague, but treat it like you discussing patient. It's really important, and you treat it like it's a real thing. And because all those cases probably are, this is a real case scenario. And I didn't, I made up a few things, but I didn't made up management or like what it came up as eventually. So this is just to show you that there is never one treatment option. Obviously, as you got taught throughout the years, leave and monitor is not an option here. So that will be a wrong answer. But if you give options of inoculation, marsupialization, blah, 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 they might even say that, what would you do next? If you haven't done biopsy, then the biopsy would be the first thing you probably would do to it. Because with the red flags, such as eggshell cracking and nerve-related numbness associated with ID nerve, you might suspect this is something nasty. So you might want to say that you basically biopsy it first, and the biopsy would be marsupialization. So it will remove the pressure from the lesion. So the lesion will start shrinking. In that case, that's how it was. So there was no need for marsupialization after that. But again, as I said, you can then marsupialize properly, or maybe at the time of the biopsy, you can just pack it with gauze, radio opaque, with some microbial substance with it, and just make sure that it doesn't close all the time. So again, it's a lot of it. As I said, would you sacrifice those teeth? Well, I would tell patients that if you will be asked to consent the patient for this station, that will be 5 minutes consent, because you need to discuss not only nerve but also teeth, and the teeth will probably go, but you only know intraoperatively.
Okay. And then we got leading on to that is, what type of biopsy would you take in this situation?
That's an interesting question, because there's only one type of biopsy you can take from this lesion. It's I wouldn't even, so if you're talking about incisional or excisional, if my understanding is correct, so it's similar to call it marsupialization or enucleation. So excisional biopsy would be enucleation. But as Owen asked me before, would I marsupialize and then enucleate? I would do that. And the benefit of marsupialization is that you take a biopsy. So, and you only take, you would take normally as much as you can, really, of the cyst. So you can send a nice juicy sample to your histopathologist. But it can be shattered as well. So then you just send whenever you retrieve, and it would usually be just incisional biopsy. So you wouldn't be normally asked for a cyst, is it incisional or excisional, because it's assumed it's incisional, and you can just say that this biopsy also can work as marsupialization.
Okay, at least you've got plenty of cyst here to send off for biopsy. There you go. Next one we got is, what is the best info on allergies or resources? Example, if a patient comes in and allergic to something you're unsure of, would you Google it, or?
In my own practice, I have lots of patients that are allergic to different bits and bobs. And to be honest, I do sedation. So if I sedate patient, then I really need to know nitty-gritties about the allergies. But again, for exam purpose, it's highly unlikely that you will have an extraordinary allergic reaction. So I wouldn't expect that you have something like lemons, or, but you might have cats and dust. That probably doesn't have much relevance, but it's probably will be somehow associated with asthma. So they will have asthma on cats and dust, and then you can basically ask more questions, because asthma is also allergy. Okay, so it's important to probe that a little bit further with asthma particularly. So you might be asked questions about asthma, etc., why it's important, and saying that you would, in day-to-day practice, you would ask how many episodes you have, when was your last time, is it well controlled, do you think? And they might even tell you that they have blue and brown inhaler, but they never really use them much. So they might have it mild, but to be honest, when they have 2 inhalers, means that it's something established. So they probably use one or another regularly. But you would benefit. So they might have asthma on exercise, they might tell you, or something,
Okay. So you wouldn't be worried about the lemons in this situation?
I wouldn't worry about the lemons, and I don't think so there's such a guideline like allergies guideline. There is just, you just need to know that if patient is allergic to something, how your management is affected. So, and it's mostly pharmaceutical, I'd say, management, maybe medical emergencies management, because once the questions are going to stop about the clinical case, we're just going to go into medical emergency. And I guess you might be thinking of what, but I might surprise you, actually. I haven't decided what medical emergency we're going to go to. Okay.
Keep us all guessing. Keep us all revising. Next one we got is, do you often see keratocysts presenting like this with marked bony expansion?
Good question. Not often, but sometimes. Again, a differential diagnosis is differential diagnosis. So I can suspect that this is a keratocyst based on the location, based on the size, some behaviors. However, it could be radicular, or it could be a melanoblastoma again. But keratocysts usually multilocular, but you can have unilocular and quite well defined as an expansion, just like that. So just basically know which is more likely, I guess, in this case scenario. and what's the treatment and what's the consequence of the treatment. So because it turned out to be keratocyst, obviously you follow up quite a long time, and you follow up only because you can leave daughter cyst behind, and it can have a certain percentage of recurrence. Now the percentage I'm going to leave to you, okay, but it has a certain percentage. And for example, if I'm an examiner and I talk about keratocyst, then I said, like, do you know percentage of recurrence, etc. So it's good to know.
Okay. Next one we got is, would you not do aspiration biopsy for cysts?
You can do it. Practically, I would do a marsupialization with biopsy, or basically a biopsy, and you can then aspirate as well, but you can actually describe in your biopsy request of what type of liquid have you seen. Is it crystalloid? Is it cheesy? Is it sort of what color it is, etc.? Is it like, do you think it's infected or not, etc.? So, and obviously, I mean, typical keratocyst would be sort of some shiny crystalloid sort of solution. You can take an aspirate and send it together with a biopsy, absolutely. But would I pierce it as a standalone special investigation? I probably wouldn't. Purely, again, in this case scenario, because there are 2 red flags I didn't like. So I just want to make a one good, solid investigation performed, and an aspiration biopsy to me in this case is more of is not a substitute. It's more of an additional, not non-standalone DLC.
Okay. And the last one I think we've got, unless anybody wants to fire one in, is, would you warn the patient of the risk of fracturing the mandible?
Absolutely. Absolutely, yes.
There we go. And then we're back in again.
Because it's, I mean, I was sort of interested what thoughts it's going to cause you that patient already have mini plate. But mini plate was associated actually with a mandible fracture that had been many, many years ago. But you would definitely warn them of risk, even if you marsupialize, even if you nucleate, no matter you do, you warn them of the pathological fracture that it just cyst has jeopardized the mandible. But again, if you would have a little bit better sort of view of OPG, then you would see board of the mandible clearer. What you're interested in this is the board of the mandible. But again, eggshell cracking noise means the cortical bone is so thinned out that you would expect that it has a significant risk of fracturing.
Okay. And then we've got, building on from my fear of cysts, is what resources would you recommend for cysts and their treatment?
Just a second. This one.
Or oral and maxillofacial surgery, and that's by Lars Anderson.
Yes, so it's Pogrel Anderson, and this is my Bible for cysts.
Okay. See the price on eBay then going up now after this.
But cysts are really small there, so I think it just encompasses all the evidence. But then again, I think it's just respecting your own profession once you graduate, that on a yearly basis you're going to be updating your knowledge in things you do. So if you do cyst every year, you're going to be sort of in your spare time, maybe even more often, just to have a look what's up there, what's clinical cases, how it's treated, what's the evidence. Because again, you're not going to be asked probably that management, but you might be asked, would you use Croix solution, or would you use cryotherapy for this? Do you know how it's done, etc.? So you probably wouldn't get into detailed question of those sort of. This is more of a oral surgery specialist level. But again, if you just mention that's going to be fabulous. That's going to be sort of way more than distinction, even probably. But yeah, this book gives you an outline, and then you can go and look into classification, because there were quite like few changes and stuff. But this book I just showed you by Pogrel and Anderson is really good.
Okay. And then the last one for this evening we've got is, would you give antibiotics for an OAC?
So if I created an OAC, I mean it's a question that I can answer in different aspects. So if I created an OAC which is less than 2 millimeters, and then I put like cross mattress stitch, I let patient go, and I see them in a week or two. If patient comes back to me and they still say, yeah, my drinks go in my nose, or it's actually painful now, etc. I have a look, they have some symptoms of potential sinusitis and stuff. Then I prescribe a classic sort of cocktail of doxycycline. Doxycycline is good for long-term communication, and some decongestion. And on SDCEP, you have first line and second line medications. So obviously, patient can be allergic to penicillin, so you prescribe then something else.
Okay. And I think that's us for the evening, unless anyone has any burning questions to ask us now. But once again, Dr. Kushnerev, thanks very, very much for giving up your Thursday evening and coming on to speak to us.
No, that's fine. Do you want to do medical emergency?
If you have time, yeah.
We can do just group too quick. So I had some questions. It's to everyone. Wonderful. So, well, basically, I mean, obviously, you can expect that the patient, you tell them that we need to, you have risk of pathological fracture, and then you notice that your patient starts sporadically breathing, and then like, oh, what did you mean? And some actors, if it's going to be an OSCE station, some actors are going to be so good, they're actually going to be performing well. So I don't know in what your departments, but I remember an epilepsy station back in the day where the patient was shaking to the point that I was just like, oh my God, what's going on? But anyway, so, and then you need to know management. GDC endorses RESA's guideline. So RESA's is your first point to go to. And they have specific instructions for what you do in dentistry. And obviously with medical emergencies now, get yourself familiar what's the differences are with COVID, because there are a few differences. Get the structure of what help you can provide. It's basic life support, it's intermediate life support, and advanced life support. But you obviously as a professional need to get your BLS sorted on a routine, on a regular basis. So you need to be updating it all the time. And if patients start showing symptoms that something is not right in your chair, then things that you start straight away is you stop what you're doing, okay? So it's important to verbalize that. You would stop what you're doing. You check for immediate potential danger. Again, probably if patient is in your dental chair, use common sense. It's unlikely that you have potential danger straight away, but you might have. And then you just go, you can call for help now if somebody else not in the room. This is classic sort of thing. And then you go for ABC. I would go personally through ABC first, but ABCDE is the full thing, and you check airway, breathing, circulation, and the rest. So disability and environment. But ABC is your most important thing, and you check it for anything that you think. If you think that your patient is in some sort of deterioration now, they're not responding to you well, you call for help, and then you do ABC. And this patient with asthma patient would normally have some problems with airways and with breathing. So although the airways might not be entirely obstructed, you can hear wheezes potentially, and it might be struggling for breathing. So then breathing will be probably more often, more frequent, but more superficial as well. Okay. And circulation with asthma patient might get cyanotic a little bit. So, and you sort of basically, RESAS gives you everything you need to know about that, from how it presents itself, what symptoms, what ABCDE you do, and then it gives you an algorithm of what's your response. With asthma, obviously, once you call for help, you diagnosed asthma, they have an asthma attack, patients probably by then actually use their own inhaler. In a scenario, patients forgot the inhaler, let's say, and then you get inhaler from emergency kit. Now you need to tell me what medication you give, what's the dose, and how many puffs, let's say. Then what if it's not helping? What do you do next? And then what's if that's not helping? When do you call an ambulance, actually? So don't forget about that. So once I mean, not all people would call it status asthmaticus, but if that's developed like severe asthma, then you call for ambulance, or if nothing helps. And in the interim, you can continue salbutamol, and you can even use adrenaline if you wish, and sometimes you must. But another scenario could come up is something like you are VT, you decided to come early today to practice. That's just to do a little bit of preparation for your list. And when you come into practice, you notice that the cleaner, I don't know, Eugene is lying on the floor, unconscious and in a paddle, and with Hoover, and Hoover is on. What do you do? And you would know it's a medical emergency scenario, so something's going on here, shifty. But you notice paddle Hoover is still working, so if you're gonna go and check the patient now, you will be the second one lying next to them. So you need to check that you're safe. So you're gonna probably turn off the Hoover, and you probably will do that at the socket. Okay, so that might be a potential sort of, just to, not necessary. They might be under something, so you need to remove that carefully, or something like that. And then you basically, obviously, then your BLS training straight away, that you should know, like, boom, 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 boom. And medical emergencies are usually there to give you points, because it's a clear-cut algorithm. There is no need to be nervous about that. You just turn on memory and what you do in this situation. And you might not, but you may as well have this station and use it as a station to get points. You can't really lose points on medical emergency. So then in this scenario, you can go, then you call for help, you check responsiveness, and then the differences is, what if somebody came to help you, or what if you're on your own? Now, it's important to make a phone call to an ambulance and say exactly what you need to say. Now, there are things that you need to say, and they are important what you say, and important to say, like, can you repeat back? So you need to make sure that there is no communication. You might even be asked, like, what if it's happened in a hospital? What number do you call? So it's good to know, again, all that information is there, been around you for 5 years. Now, do you know your medical emergency phone number, your crash team number? Do you know if it's 2222 or is it 4444? I mean, and again, once it's done, what do you do next? You need to know, do you start CPR? Do you go look for a automatic defibrillator? Then you might be asked questions on automatic defibrillator, or you might be asked a couple more questions as well about medical emergency. Like, for example, when do you stop CPR? Now, CPR you would stop if you're exhausted. I mean, you can't get yourself into heart attack either. Okay. And you might stop CPR when there is a help arrived and you swap over, or you might stop CPR if patient is conscious, obviously. And that's important. I mean, it sounds funny, but obviously you need to imagine that in this situation, when that happen, highly unlikely you'll be continuing CPR anyway, but you need to verbalize that. So if patient regains consciousness, then you would stop CPR as well. And then the next question, so patient regained consciousness, what do you do? And then you say, I'd stop CPR and I get patient in recovery position and cover them by the blanket. And the main important thing as well, I would continue monitoring them, because they can go into heart attack again. Okay, so they cardiac arrest even, sorry. That's pretty much it. But know your medical emergency kit. You might be asked questions about medical emergency. You can ask questions like, what dose of adrenaline you give in anaphylactic shock, or where do you give it, or what's hypoglycemia, etc.